Welcome everyone. My name is Dr. Anne Lomole. Welcome to the South Sudanese Women Intellectuals Forum. For those of you who are watching us on our Facebook Live, welcome. And for those of you who are watching from YouTube, we welcome you. And feel free to share this discussion on any of your pages and with your friends and family, because we are having a very important discussion today. So my name is Dr. Anne Lomole, as I said before, and I am a pediatrician and infectious disease consultant. I will be your moderator today for this topic. We will be discussing reproductive health and rights in women. And this is a very important topic for us, especially as South Sudanese women, because I feel that many of us do not know what exactly reproductive health and rights entail. And for us to be able to advocate for change to ensure that our reproductive health and rights are respected, we need to have that knowledge and that information. And we hope to achieve that with this topic today. According to the UNFPA, good sexual and reproductive health is a state of complete mental, physical, and social well-being in all matters that relate to the reproductive health system. And it implies that people are able to have a satisfying sex life and that they have the capability to reproduce and the freedom to decide if, when, and how often to do so. To maintain one's sexual and reproductive health, one must have the knowledge, they must have accurate information on safe, effective, affordable, and acceptable contraception methods of their choice. On top of that, they must be informed and empowered to protect themselves against sexually transmitted infections. And when they decide to have children, women should have access to services that enable them to have fit pregnancies, safe deliveries, and have healthy babies. So the denial of these reproductive rights leads to increased poverty and gender inequality. This is actually an equality issue. And when reproductive health needs are not met, then people are not given the opportunity to make the crucial decisions about their bodies and their lives. And some of the consequences of this denial of reproductive health rights cascades into future generations. And this is something that we need to be aware of. So we hope that this discussion is going to create awareness about reproductive health and rights, and we can become advocates, not only for ourselves, but for also our fellow women. And today I would like to thank our panel of experts who have graciously agreed to join us for this discussion. And they will be speaking on various aspects of reproductive health, including clinical aspects, best practice, nutrition, policies. They will also be speaking about some of the cultural aspects and myths associated with some reproductive health issues. And we'll also have recommendations on some of the things we can do about the challenges that are faced when it comes to ensuring the reproductive health and rights of women. So please do not hesitate to ask any questions on our wall. This is to the audience. And for the questions that we're unable to answer during this discussion, our panelists have graciously agreed to answer at the end of the discussion. Thank you so much for joining us, and feel free to share the link in all your social media sites. So we'll go straight into the introductions, and we'll start with Dr. Kiden Annette. Dr. Kiden is an obstetrics and gynecology resident. She works at Kenyatta National Hospital, which is the premier referral hospital for Kenya. And she is doing her master's in medicine in obstetrics and gynecology. She also has an undergraduate degree in medicine and surgery from the Kampala International University. She has a passion for women's health, and today she will be the one discussing the clinical aspects and best practices of reproductive health. So welcome, Dr. Kiden. Next, we would like to introduce Dr. Ayak Chol.
Thank you.
Dr. Ayak is a peace builder and currently serves as the head of research at the Strategic Defense and Security Review Board, an implementation instrument of the revitalized South Sudan Peace Agreement. She is also the former deputy coordinator of the South Sudan Civil Society Forum and one of the co-founders of the Anna Taban Youth Peace Movement. She is an active member of the South Sudan Women's Coalition for Peace and a staunch women, peace, and security advocates. Dr. Ayak is also a certified grassroots mediation expert, a practicing and a clinical epidemiologist. She's also a published poet and researcher, and she holds a Bachelor of Medicine in Surgery and Masters of Public Health in Epidemiology. Dr. Ayak is a practicing political analyst and a human rights activist and a certified facilitator at the National Transformational Leadership Institute. Welcome, Dr. Ayak. Next, we would like to introduce Nyagwa. Nyagwa has extensive experience both in the public and private sector. In the public sector, she worked for the government of South Sudan between 2008 and 2011 at the Ministry of Investment and the Ministry of Foreign Affairs. Thereafter, she was involved in entrepreneurship, starting a fashion brand known as the House of Bani, and her designs have been showcased in various fashion shows in Kenya and South Sudan, and most recently in events that promote peace, like the Fashion for Peace in Nairobi and the Festival of Fashion and for Arts in Juba. She's also a founding member of Anataban Youth Peace Movement and a co-founder of the Catwalk to Freedom, which is an organization that helps to protect girls who are at risk of being forced into early marriage through fashion, photography, and film awareness. She's very passionate about protecting the rights and advocating for the rights of women, girls, and refugees, and is also a proud mother of 3 children. Welcome, Nyagwa. Next, I would like to introduce Ms. Ganiri Jaslina, who is a nutritionist and a public health practitioner. She strongly believes that health is more dependent on our habits and our nutrition than it is on medicine. And she has a specialized interest in nutritional care with expertise in infant and child feeding, and has worked in Nyambio State Hospital. She's worked with the World Vision International, and she's also worked at Mbagathi District Hospital in Kenya. She holds a first-class degree, Bachelor of Science in Human Nutrition and Dietetics from Kenya, and she also has a master's degree in Public Health from Clark International University. Welcome, Ganiri. We would like to also introduce Dr. Alek, who is currently not on the screen with us, but she will be sorting out her internet and will be on the screen. She has over 10 years experience in various capacities. She is a veterinary doctor and is currently a lecturer at Juba University. On this panel, she will be speaking to us as an expert in HIV/AIDS. She is a HIV prevention specialist and has worked at HIV/AIDS Alliance, and is also as a deputy program director at the SPLA HIV/AIDS Secretariat in Juba. She's a civic educator and holds a master's degree in the control of infectious diseases from the London School of Tropical Medicine and Hygiene, and she also has a Bachelor of Science degree in veterinary medical sciences from Egypt. She has participated in the development of the South Sudan HIV/AIDS Strategic Plan from 2013 to 2017, and she also holds various capacities at community level. Then we would also like to introduce Ms. Viola Riak, who is a social scientist and a gender activist currently based in South Sudan. She works with the UNFPA as a gender analyst and has over 8 years experience in peace building, conflict resolution, and gender equality. She is a champion on prevention of gender-based violence, including child marriage, and a strong advocate for issues of reproductive health. She also advocates for services including the right to access family planning. She holds a Master's of Social Sciences in Social Studies from the University of Cape Town in South Africa and a Bachelor of Arts in Community Development from Daystar University. So thank you very much, our panelists, for joining us. We're very grateful that you have taken your time to be able to discuss this topic with us, and we hope that today will be a very informative session for our audience. So I will go right into the discussion in the interest of time. So Dr. Kiden, we will start with you. If you could unmute yourself.
Yes.
Thank you. So Dr. Kiden, the first question goes for you. I think you will be able to set for us the stage for this discussion. If you could just, in your own words, briefly define what reproductive health and rights are, and what do they encompass? What are the reproductive health rights?
All right. Thank you very much for having me. As Dr. Ann had
Sorry,
alluded
Dr.
earlier
Kiden, we
on,
can't hear you.
that
Can you
reproductive health.
hear Dr. Kiden?
Oh, sure. I can hear you very well, and I think, I don't know. Can you hear me now? Hello.
I'm sorry, Dr. Kiden, I don't seem to be able to hear you. Can you hear Dr. Kiden? You can hear Dr. Kiden?
Hello. Yes,
Okay,
I can hear.
can hear you. So I
Hear you,
think you
Ann.
go ahead and go ahead with the discussion, Dr. Kiden.
All right. Thank you. And as Dr. Anne had alluded earlier on, reproductive health, from the academic point of view, is the physical, mental, emotional, and social well-being, and in matters concerning your reproduction, and not merely the absence of disease, dysfunction, or infirmity. So you see that from that definition, you realize that there are 4 faculties that you need to pay attention to when they talk about reproductive health. The aspect of physical health is something to do with a disease process that can happen to you in your body, and this disease process can potentially affect your sexuality or your reproduction. But I want to point out that the reproductive system does not function independently in the body. It has got many other sections that we get from the other systems in the body, because the body functions holistically. So any problem in the body can potentially affect the reproductive system, because the reproductive system does not only mean from outside the external genitalia to the gonads. That is not all. Its function is potentially influenced by other organs in the body or other systems. So when we talk about the physical health, that is to do with your physical well-being. But there are also those other functions or other elements of reproductive health involving the mind. This is your mental faculties. How well are you functioning up there such that your reproductive health is considered to be healthy? If you're stressed, you may not be able to function well in your reproduction. The same thing with the emotions. If your emotions are affected, I want to announce to you that you may not achieve much, even when you may not have any dysfunction in your reproductive system. How about your social well-being? How are you relating in the house? How are you relating with the community? Are there things that the social spheres around you that can affect your reproductive system? So reproductive health is holistic. It is not merely the absence of disease, dysfunction, or infirmity. So it encompasses all those things. For you to declare that you're sexually or reproductively healthy, these 4 areas of your life must be healthy. So the problem comes in balancing them up. That is where the catch comes. So the other question is that The other important part of reproductive health that we must pay attention to is that you must be able
Thank
to.
you so much, Dr. Kiden. Thank you so
All
much,
right.
Dr. Kiden, for that awesome discussion. I think you have given us quite a great overview on what reproductive health is. So you can mute yourself, and we'll go straight to Dr. Ayak. Dr. Ayak, if you could unmute yourself. Dr. Ayak? Okay, so the next question
Right
goes
here.
to you, Dr. Ayak. And I'd like to ask you briefly, what do you think are the cultural, social, and religious issues that affect women's reproductive health, especially from a South Sudan perspective? The cultural, the religious, and the social issues that affect reproductive health for our women.
Thank you so much. Building on what Dr. Kiden just mentioned, that reproductive health, right? Reproductive health is all encompassing. So we have the cultural issues, we have religious issues, and we have social issues that have, have caused challenges to the reproductive health of South Sudanese women. Some of those things are, for instance, early and forced marriage. There is a particular age in which a woman is expected to be married. So, and most of the times those are ages where the woman is, it's a girl, she's underaged. We also have the culture of forcing women into marriage, and that affects their psychology, and also affects intimacy with their partner, which then is also considered marital rape. We have issues of polygamy and multiple sex partners. And that particularly from the aspect of us being a patriarchal country, where we come from a country that is very much patriarchal, and as such, a man is seen almost permitted to have multiple sex partners. And this is usually done, and the sex itself is unprotected, and that predisposes the other sexual partners in that relationship to sexually transmitted illnesses, and of course the other psychological aspect of it as well. We also have issues of wife inheritance, particularly in our Nilotic communities. If a woman's husband dies, she is automatically expected to be inherited by another male in her husband's family. So that could be his younger brother, or that could be his oldest son if he's an elderly gentleman, and so on. We also have cultural issues like bride kidnapping, all the way from Eastern Equatoria, all the way, to Barghazal and Upper Nile. It is a very common practice due to the high dowry cost. Most of the times, young people have a tendency to kidnap girls and ensure that and hold them hostage until they're pregnant, so as to waiver the dowry or make the dowry a negotiable thing. That is also one of the serious challenges. Additionally, as South Sudanese, from not just from a religious perspective, but also culturally, the husband is the head of the household, the wife is the helper and the companion. That relationship sometimes, if it is not well balanced, if it is not well thought out, it leaves the woman in a servitude type of situation, and that does not give her autonomy over her body. I think I also want to add in religions, Catholic, Islam, and then many other religions, even our culture, there is the sanctity of life. There is the and so this brings in the abortion debate, which hopefully we'll delve deeper into later on. So there is that. There is a lot of debate on the sanctity of life, on whether a woman can procure an abortion or not, and generally taboo and the stigma around sexual and reproductive health rights, to a point where, for instance, if you are having, if you are practicing sex, and you as a woman ask your partner that, no, I would need a condom, for instance, the assumption would then be that you are a prostitute or you are a loose woman. So there is that as well. There is that, the dichotomy between the rights aspect and, being considered lewd and disrespectful and all over the place. That is also a debate, hopefully, that we should delve deeper on and further into the discussion. Thank you very much, Dr. Ann.
Thank you so much, Dr. Ayak. I think that's very interesting. The fact that culture might view as lewd and as someone who slips around if you demand for your reproductive health rights in terms of contraception, whether it's oral contraception or condoms. And it's, I think, a discussion that we should actually look into, because that then creates an imbalance of power between the woman and the man, and the woman will be trying to decide whether they should actually demand for their rights or not. And that might actually cause an issue in them accessing their reproductive health rights. And when you talk about kidnapping and being forced into marriage, and the assumption is that this kind of tradition should have died with our ancestors. However, some of our communities are still practicing it, and we need to really protect our girls from this kind of scenarios. So next we will go to Miss Viola. Miss Viola, the next question is for you. If you could unmute yourself. Miss Viola. Okay. Miss Viola, can you hear me? If you could unmute yourself. Thank you very much, Miss Viola. So Miss Viola, you have worked with the UNFPA and have been surrounded with people who come up with policies that have to do with sexual and reproductive health, and specifically for women. And if you could just give us a brief overview of what the indicators used for monitoring reproductive health are, and whether we actually have statistics for those indicators and for UNFPA.
Okay, thank you very much. As you have heard from the previous speakers, it is very important to note that some of this data is now 10 years and older and require updating situation. But I will just give you a clear, just briefly, what are our indicators and how they look like. So here in South Sudan, as you know, we have the worst maternal mortality rates in the world. And we have a maternity mortality rate ratio which stands at 789 per 100,000 deaths. We also have infant mortality rate which standing at 84 per every 100,000 birth. We also have child mortality rate which is under 5, which is 106 or 100,000 children. We have antenatal care, so the World Health Organization gives a minimum of 4 visits. So those women who are sending antenatal care four times is 17% only of the pregnant mothers. We have 88.5% of deliveries which are being done at home. We have stillbirth rates, stillbirth attended, so only 40.7% are attended by stillbirth, and we have over 360,000 women with obstetric fistula. It is estimated that 7.5 each for each woman in South Sudan, so the total fertility rate stands at 7.5, which is very high. We also have a very low contraceptive prevalence, which stands currently at 4.7 for all, but it is 1.7 for the modern contraceptive. We have unmet need for family planning, so those women who want to get to family planning but are not able to find at 26%. And we have other issues like adolescent birth rate, which for every 1,000 deliveries that are happening in South Sudan, 158 of those are adolescent girls. The difference in South Sudan is 30%, and we have a proportion of women aged 20 to 49 who are married or are in union before they turn 18 years. So basically, that's how our indicator is looking like. And quickly, I'll go to the policies that are in place and UNFP and government are doing. So just to touch briefly on
Ms.
the
Viola,
I want to take
Ms.
note that
Viola, sorry to interrupt you.
comprehensive policy to support.
Ms. Viola, sorry to interrupt you. It seems that people are not getting you clearly. If you could, okay. So Mr. Viola has dropped off. I think there's a bit of an issue with internet. I think she'll be coming back on when we've sorted that out. So we'll go to Miss Nyagwa. If you can just unmute yourself, please. Miss Nyagwa, could you please unmute yourself?
Okay.
Okay, thank you so much.
Yes, I did. Can you hear me?
We'll go to you because I think some of your questions sort of cross over with Miss Viola's question. And I know you have a particular passion and a place in your heart for the refugee women and have worked with them. I wanted to know, what are the issues that they face in terms of access to reproductive health services, in terms of the inequalities that are specifically for refugee and vulnerable populations? What are some of these inequalities that they experience as refugee women?
Okay. Thank you again for the question. I've worked in Kakuma mostly, and recently, in the last 2 years, there is a lack of reproductive health education. And there's a need, and there's a way we need to approach a different way of educating young South Sudanese girls and women in Kakuma. And from my experience, a lot of young women and a lot of young girls are afraid to go and ask for help, especially the refugees camp. This cultural norm comes in, and also access to healthcare, especially in Kakuma, is very difficult for the refugees, young girls, to go and access that. A year ago, I was in Kakuma and I spent 2 months there, and we had a small funding to do sex education, and we got a lot of backlash mostly from the fathers. Why are we educating the young girls about this? But to my surprise, a lot of young girls actually showed up for the meeting, and they kept saying, we need to be educated, we need to understand our bodies. But in where they are, they don't have access to those information. So we need to redirect, we need to educate young South Sudanese girls in the refugees camp. We need to figure out a way how we can educate them and also respect our cultures at the same time. So that's what I encountered when I was in Kakuma.
Okay, thank you very much, Ms. Nyagwa, for that brief explanation of what some of the inequalities that refugee women experience are when it comes to healthcare. Thank you so much for that insight. Next, we would go to Dr. Alec is not with us right now, so we will go to Ganiri to tell us a bit about nutrition. Ganiri, if you could unmute yourself, please. Ms. Ganiri. Thank you so much. Our question for you today is, we know that nutrition is very interlinked with reproductive health. And despite all the other issues that we think about the growth of the baby, there are other things that we don't usually mention when it comes to nutrition and reproductive health. So could you please enlighten us on what aspects of nutrition actually affect reproductive health, and especially the impact of obesity, undernutrition, and micronutrient deficiencies?
Thank you so much, and it's glad for me to be here, talk about my passion. You can hear me well? Yeah. When obesity greatly affects reproductive health from preconception up to postnatal. So when talk about obesity, about 9.5% of women are obese of reproductive age. That means having BMI of around 30 kilograms per meter squared. Obesity greatly is associated with an ovulation, and we can also talk about gestational diabetes. When later on they conceive, there's a tendency of gestational diabetes with obese mothers, and this gestational diabetes is linked up with overweight children during birth, infants, because there's a lot of insulin resistance, and the baby absorbs a lot of glucose during conception. So it's really associated with a lot of overweight babies. We can also talk about hypertension and during pregnancy, the preeclampsia during labor also. So obesity really greatly affects leads to hypertension in pregnancy. We also talk about other infertility scenarios or in obese mothers or obese women. So it's really leads to infertility or miscarriages due to ovulation disruptions on ovulation and all that. So it's really a great factor. Briefly, it really affects the reproductive health. Also, when talk about underweight, which means somebody having a BMI below 13 kilogram per meter squared, the underweight during preconception, girls tend to have desires for better shapes and looking healthy, but they end up not actually having the good health we are looking for. So they end up into the anorexia nervosa or the bulimia. So whereby they eat and they induce maybe vomiting for the bulimia, or deliberately stops eating. And as Dr. Kiden, I think, has talked about the psychological part of it, they think they are big initially when they're actually not big, so they end up having anorexia nervosa, so they don't eat. So this underweight greatly affects the nutrient content of a pregnant mother. So she may end up having deficiencies. Maybe we know very well during pregnancy there's increased need for folic acid it can increase up to around 300 to 600 micrograms of folic acid. So there's also need of increased iron demands in a pregnant woman, and this lasts up to even after delivery, preconceptions. So part of this question also was also about to talk about the supplements, and for sure supplements are very important during for better reproductive health, and particularly folic acid and iron. The point of it, at some point, the medics know very well they do supplement women even after delivery. Maybe if she was overbleeding after delivery, they also give them iron supplements just to boost up that high demand for iron during pregnancy and after for her better healing. So we also talk about vitamin D. We know very well it's very important for the growth of bones and other organs in the baby. So it's very vital. So we talk about extra calories during pregnancy, around 300 extra calories daily for a pregnant woman, because not during conception and also postnatal there is high demand of calories for the breastfeeding. So we end up it's also very vital for somebody to have a good amount of calories. So in this process we need to also mind our weight with the normal exercise. And I had talked about something called my plate. We know very well we need to have a proper diet of what we are eating. So as you look at a plate, the normal plate we're eating, half of the plate initially is supposed to have vegetables, not acida, not our carbohydrate grains. It should have the vegetables. So these vegetables not only help us with the vitamins and the minerals, they also help us with constipation. We know very well during pregnancy, there's slow digestion. So women tend to have a lot of constipation. And there's less activities. So they're not so physically active, so they end up having a lot of constipation processes. So and it also helps us with this obesity controlling. So during pregnancy, we really mind what is called my plate. Due to time, I'm not able to share the slide of my plate, but we know as a plate, full plate, half of it should be vegetables. We have a lot of vegetables, cucumbers, the leafy korofo, as we eat gadia, there's a lot of vegetables back in South Sudan. Kudra is good, a lot of it, okra. So half of the plate should actually be the vegetables. Then the other half now, you divide it into two also. So the other quarter, we can have now the carbohydrates, our asida, our cassava, our sweet potatoes, our kisra. So we have it in that part. Then the other half of the plate, it compensates for the protein, the beans, the meat, the chicken, the fish, and other maybe mushrooms. So we have a lot of variety of proteins proteins in our country. So this way we shall be able to have a good weight, not really obese weight for the pregnancy. Yeah. So this is all we really have to, and also the exercise. So obesity will end up, so that way we shall be able to present those conclusions that I talked about earlier of hypertension, diabetes, and all that.
Okay, thank you very much, Daniel. I think basically what you have told us is that both extremes are bad, whether you're obese or whether you're underweight, both extremes are bad, and they can be bad for your health and also bad for the baby. And you should ensure that you get adequate nutrition and follow the adequate concepts that is able to balance the types of nutrients that you get in, and that specifically in pregnancy you need more calories than in when you're not pregnant. And the fact that micronutrients are very, very important, especially iron, vitamin D, and what we call folic acid, that protects the unborn baby from what we refer to as neurological disorders. Thank you so much for that overview. Next, I would like to go back to Dr. Aya. If you could unmute yourself. Thank you. When we talk about some of the reproductive health rights, women have a right to decide when they want to have babies, if they want to have babies, and how they want to have babies. And one of the most important things that help us have those rights is contraception, which is something you talked about when you were talking about where community views someone as used because they're demanding for contraceptive methods to be used. So could you please define for us what the unmet need for contraception is? And I think probably Viola might have mentioned some figures, but you can repeat what the South Sudan figures are. And if you could talk about the myths and misconceptions around contraception and a brief overview of how we can dispel these myths and what the types of contraception are.
All right. Thank you very much. Just to avoid repetition, Ms. Viola already spoke on the statistical figures related to, reproductive health rights and also the aptitude towards contraception. So I'm going to just gloss over the myths and misconceptions. And the most common one is that contraception means that you do not want children. And that could be so, but it is not necessarily only that. So there is that. There is the assumption that if you choose contraception, it means that you do not want to have children at all, that you choose to not have children and just, not be a mom. And they're not necessarily mutually exclusive. You could want to have children and still choose contraception, or not and still choose contraception. And there's also the second notion that contraception causes infertility. That if you choose contraception, the chances of you conceiving after stopping the contraception, goes to zero, which is not true. as soon as you stop using contraception, based on the type of contraception that you're using, your hormones pick up and you can conceive immediately afterwards, as soon as the next month to 3-4 months afterwards, especially the reversible types of contraception, which we will go deeper into. There is also the assumption that particularly women who choose contraception are loose. They want to just have a good time and be all over the place. And that cannot be furthest from the truth. The moderator already has explained that it is a reproductive health right to seek for your safety. Your safety, and as Dr. Kiden also spoke earlier on, it is not just a physical, it is also psychological. You do not want to expose yourself to STIs. You do not want to expose yourself to the stress of maybe I could get pregnant, or maybe I could have a disease. So there is also that aspect that you, by choosing an appropriate type of contraception, you avoid all that drama. I think best ways to deal with this, and I think there are a lot of organizations out there at the international level, like WHO and UNFPA, UNICEF, and others, and local organizations, like Catwalk to Freedom and other, like Crown the Woman, and social media platforms like Gender 211, who have been challenging the norms and sensitizing the masses through gatekeepers at the grassroots level and women leaders, to social media where people discuss issues on sexual and reproductive health that would otherwise not be discussed, gender balances. I think for me, on a personal level, I think the most important issue is introducing sex education at school level. And I know, it will take a while to get there, but I am sure with the turning times and with the caliber of cadres that are now coming into positions of power, I think we as women have that upper hand to negotiate sex education into school curriculums. For instance, at 4 years old, I remember my son being told private parts, nobody should touch them. And that is at nursery level. And that is the beginning of sex education. You want to, first teach your children about privacy, and moving on to when they're 10, and, not mincing your words, but actually telling them there is a penis, there is a vagina, penetration happens, this happens. So we need to destigmatize and just take away the taboo from these talks. Moving on to the type of contraceptions. So I'll start with the natural type of contraception, the contraceptions of our grandmother's days. The first one is abstaining. You know that if you do not have sex, there is no way you're going to get pregnant, because contraception is all about regulating and preventing pregnancy. So the first one is abstaining. The second one would be having sex during your safe days. And these sometimes, can be a little bit skitty, because first of all, women, our bodies are so unique, and our periods are very diverse, and our safe days depend on the range of our periods. So you need to really get down to the nitty-gritty and understand when your safe days are. And you might not be 100% safe, because again, the sperm can stay alive and well inside our reproductive system for up to 72 hours. So there could be a chance of fertilization if you're not careful. So there is that. You have to understand the science behind it. Then there is what is known as the pull-out method, and the challenges is that when you're caught in the heat of the moment, it is very difficult to tell your partner to pull out. You might not want your partner to pull out at that time. And if they pull out, there is pre-ejaculum, pre-cum in layman language, which sometimes it is meant to lubricate, the sexual process. But sometimes, there is a stray away sperm, and so it is not something that is 100% 100% safe. Then we have surgical methods, vasectomy, where you know, they cut the cord that is connecting the testes to the sperm, to the penis, and so the ejaculum is semen only, so there is no sperm. The sperm is reabsorbed into the body, into the man's body, and these is 100% functional, but you have to you know, have practice safe sex in the beginning for a while, because there is some sperm that could still you know, find its way, especially the same day or the next day. There could still be some sperm lodged somewhere, and you know, yeah, it could work against you. But it is 100% guaranteed that once a man has a vasectomy, then, you know, there is no chances of him impregnating a woman. For me, I prefer that, of course, because men don't get pregnant. And if a woman has, you know, sex with how many people, a woman would only get pregnant once. But that man, you know, if they're able to have sex with 365 women that year, 365 of them might get pregnant. The other one is the tubal ligation, and that is you know, ligating, tying, which is tying. Ligation is tying of the tubes, yeah, tying of the tubes, of the fallopian tubes, and that of course then prevents the travel of the sperm and also prevents the descent of the ova, and therefore there is no fertilization that happens. And also those are, you know, the chances are extremely high of not conceiving. Then we go into the physical contraception, which is the male and the female condoms. We have one of our very prominent young South Sudanese men, Data Gordon, and he's on a condomized campaign that is to distribute free condoms to young people in South Sudan. There is also the intrauterine devices, and they're different types. And these are devices that sit in your uterus to prevent the implanting of the zygote, of the conceived, you know, of the baby. So and then the last one, we also have implants, which could sometimes in the arm or in the wrist or anywhere in your body. These are also usually an implant that has a chemical hormones that are released slowly over a period of time, and you know, it is usually preferable for people who want to not get pregnant from 3 to 5 years. So it is a very good type of contraception, and its chances are very high. Unfortunately, you have to be monitoring as well, because in the beginning you have to build up the level of hormones, and at the end the level of hormones goes down, and as such you want to be on the lookout. And then lastly, but not least, is the chemical, you know, the well-known chemical ones, the emergency contraception. I will feature it here because it's very important we talk about it, that emergency contraceptive pills can work up to 72, sometimes even 5 days after intercourse, although its effectiveness decreases with time. It is a very effective contraceptive tool, pill that, you know, if it happens that you have had an unprotected sex, then it is a viable option to prevent fertilization from happening. And right after that, we have the combination pills, the pills that come in a bag, you know, they're like 28 pills, and you have to follow through all of them, you know, line by line, line by line. And these are exceptionally good, especially for younger people, because they help regulate your hormones. As soon as you stop them, you know, the possibility of conception is immediate. So it has additional benefits to regulating your moods and all that. And especially for people with, you know, other reproductive health issues, it is highly recommended. Then we also have the progesterone only pill. There are these myths that if you are lactating, if you're breastfeeding, you cannot get pregnant, which is the farthest from the truth. I don't know how many people have seen a woman, you know, with a child tied on the back and another younger one breastfeeding and maybe another one in the tummy. For women who want to regulate their pregnancies, then it is recommended that they do take the progesterone only pill, because it is highly effective for women that are lactating, that are breastfeeding, because we have prolactin, the other hormone that is being released as the woman is breastfeeding. They both combine together and they offer contraceptive abilities, effects. Thank you very much.
Thank you so much, Dr. Ayat. I think you've actually gone into most of the details, because you've given us the types of contraceptives. You talked about the myths. You talked about some of the effects of the contraceptives, and we haven't gone too much into the details of the side effects. But I think you also talked about why one would choose one versus the other. And we wanted to ask Dr. Kiden also to expound more on that, but I think you've cleared the air when it comes to contraception. So Dr. Kiden, your next question, the next question will go to you. I think Dr. Ayat has done a very good job with the contraception question. So for you, we would like to ask, I think Dr. Ayat has talked about contraception and people relating it to infertility. So could you please just give us an overview? What is infertility, and what are the causes? How is one investigated for infertility, and what are the treatment options? And maybe you can also talk a little bit about how the society contributes to stigma when it comes to infertility, and how can we be part of the solution? Thank you.
All right, thank you very much, Anne. Infertility is a very major problem in the community. So how do we define infertility? What is it exactly? So medically, we define infertility as inability to conceive after having regular unprotected sexual intercourse for a full year. That is when we will recognize that for sure this is infertility. So what happens usually is that when a young, healthy couple is married, or a couple may not be married, within the first 1 month, couples are able to conceive up to 25%. Supposing you have 100 couples, 25 of those will conceive within 1 month. 25% will conceive within 6 months, and 70% within 25 within 1 month, 70 within 6 months, 90% will have conceived within the whole year. So the other 5% would not have conceived, and so there we declare them to be infertile. So the types of infertility that people do experience, we have what is called the primary infertility, where a married couple or a girl has never conceived at all. Secondary infertility is when you have conceived and thereafter have difficulty in conceiving. So the first pregnancy may not have succeeded. In other words, it may have been an abortus, or it would have been an ectopic pregnancy. So the moment you have registered clinically that there was an occurrence of pregnancy, then you fall under what we call secondary infertility. What are the causes? We have infertility itself can be caused by many factors. We have the female factors and the male factors. But unfortunately, most of the time in our African communities, we think that infertility is only from the woman. But scientifically, it has been proven that 50% of the cases of infertility are caused by by female factors, and the other 50 is caused by male factors. So when you are managing infertility, you should bear in mind that we should investigate both the man and the woman. It should not be a woman issue. All right. So what causes infertility in the woman? In the woman, we have got factors that arise from the ovary itself, the organ that produces the ovum in the female. We have got a problem that can be in the transportation of the ovum from when it is being released to go into the fallopian tubes where it can be fertilized. If there is a problem in the transportation of that gamete, then that can cause infertility, because that means that the sperm will not be able to meet with the egg for fertilization. Okay, and then we have so I have talked about defective ovulation, where the problem is arising from the ovary, and from the ovary, you see, it is where it is generated. So if the problem arises from the production of the ovum, then even when they produce something which is not functional, then that can lead to infertility. Then also in the ovary, we can have ovulation being interfered with due to nutritional factors. If somebody is obese or very lean, as Dr. Jacqueline has already alluded earlier on, then that can cause infertility as well. Then we have also what is called endometriosis. Endometriosis is a disease whereby the uterus, the place where the egg is supposed to implant, that lining of the uterus, if those glands are found elsewhere outside the uterus, when you get your monthly menstrual cycles, those glands that are located from elsewhere, what we call epitopic endometrial tissue, they will continue to also behave as if they want to undergo the normal menstrual cycle. Actually, those glands can bleed within themselves and cause a lot of pain during sexual intercourse, a lot of fibrosis or adhesions inside your body, wherever they are located, and they can cause adhesions that can lead to tubal blockade. And so that can be one major cause of infertility, and it's a very stubborn condition to be treated. It causes a lot of distress. So that is one of the causes. The other most important thing is that I've told you that defective transport, which means that the tubes can be blocked, and then the ovum. Hello? We continue? All right. So defective transport, then we have got defective implantation, whereby the problem is that the uterus will have structural deformities that can be caused by masses like fibroids. It would be that there is...
Yes, Dr. Kiden. Continue.
Okay. Okay. All right.
Thank
so
you.
Fibroids can cause infertility because it distorts the anatomy of the uterus. The other major thing that I want us to hear very well is that the uterus can undergo what is called adhesions or synechia, where the endometrial tissues, the endometrium or the uterine cavity where the baby is supposed to implant, undergoes fibrosis and closes up. And that can result from procedures that we call the evacuations or manual vacuum aspirations of the uterus. When you have an incomplete abortion and you undergo this procedure, sometimes there can be a damage in the endometrium, and that can cause problems with the implantation, resulting into infertility. All right. So in the male, they can also have problems with the production of the sperms. If there is a poor production, which means that they are not there, the semen does not have sperms, or the sperms may be there, but they are dysfunctioned because of the morphology, or maybe they are dead. So that can also cause infertility in a couple. The other thing is also they can have obstruction, the transportation of the sperms from where they're manufactured from to the point of being put into the woman and traveling up to fertilize the egg. There can also be physical defects. Sometimes with these men, the urethral orifice is not located in the proper place. It could be behind or could be up. It could be in a funny position, whereby even when it is during sexual intercourse, the sperms are not deposited in the correct place. Now, how do we investigate infertility? I had already told you earlier on that the problem of infertility is a couple problem. It is not a woman's problem only, as many of our communities do think. So we have to investigate both of them. So if you are infertile, you have to go with your partner to the doctor. What will the doctor do to the woman? The investigations, we have got to see whether your endocrine function is functioning very well. And this endocrine function is composed of many from different organs, like the ovaries produces hormones, the hypothalamus, the pituitary gland produces hormones, and also the thyroid gland and the adrenal glands, all those contribute hormones that can affect fertility in a woman. So we do what we call endocrine screening or investigations. We make sure that we are sure that you are ovulating. Are you producing eggs? So we do investigations that will tell us whether you are actually in position to produce those eggs or not. And that we can do by either taking your temperatures, we do hormonal profiles, and the other important investigation that we have to do is to make sure that we see that your endometrium has got the receptivity for the egg that is coming or the fertilized ovum. So we do endometrial biopsy, we take part of the endometrium and we examine it, whether it is able to conceive. The other very important investigation that we have to do is what we call the ultrasound, to see whether the follicles in the ovary are being produced in the correct time. And so we can have what we call the transvaginal ultrasound or the abdominal ultrasound to ascertain that for us. Another important investigation that we usually do right now, and it is the gold standard in investigations of infertility, is what we call the laparoscopy, where we do surgery or microscopic, for that matter, surgery, where we look inside and we see, is the abdominal cavity and the pelvic cavity, is it okay? Are there no adhesions resulting from endometriosis? Are there no adhesions resulting from infections like chlamydia? Are there no masses inside the ovary that we can demonstrate in that procedure and see what is the problem with your structures in there? Another important investigation that we have to do in the woman is what we call the hysterosalpingography, HCG, where we inject in a dye and take X-rays and see, and this helps us really to give us an outline of the endometrial tissue and also the patency of the fallopian tubes. So usually women go there and we prepare them and we take those photographs and images and we make sure that the anatomy is okay. The other one is that we can actually put there machines to look inside from the vagina, what we call the hysteroscopy. We look inside, and this also will help us to identify whether the anatomy of the uterus is okay, because most of the time we can have infertility resulting from congenital malformations of the uterus. The uterus can have a big septum in between, and it therefore distorts the cavity, and the implantation can be impaired The other important thing is that we look for masses, things like polyps and the fibroids. That is a common occurrence, and adhesions. Then we look at the cervix. The cervix sometimes can be closed up, more especially resulting from surgical procedures like when you go for screening for CA cervix. When there is a problem there, sometimes we cut part of the cervix, get it out, and in the process, it heals by fibrosis or it heals by scarring and closes up the cervix. And if the cervix is closed, it means that all the sperms are closed out, and that can come with many other complications as well. Another investigation that we do is to see whether the environment in the vaginal cavity and in the cervix is not hostile to the sperms. And so we do what we call the anti-sperm antibodies. Sometimes the ladies can produce antibodies against the sperms. So the moment they are deposited inside the genital tract, they are killed or they are denatured. And so at the end of the day, they lose the capacity to fertilize. Male infertility, we can investigate it by doing the urinal seminalisis. We take a sample of the semen, and we take it to the laboratory and investigate whether it really has got the capacity to, or the sperms, are they there first of all, and if they're there, are they morphologically normal? Are they able to swim through? Because from where they are deposited, can they go up and they maneuver their way to meet their egg? So we all look at this in the process of seminalisis, and we can also do ultrasound. We look at the anatomy of the scrotum and see whether the very place where the sperms are manufactured from is functional. Is it there? Then we can do also testicular biopsy, and we analyze it and see whether it is functional. We can do hormonal profiles as well in the male. So how do we treat infertility? So now the treatment of infertility is mainly patient dependent, depending on what is causing your infertility, right? And then also it depends on the age of both partners. The way we treat young couples would differ from when we respond to a couple that is almost the sunset, right there when you're nearing your menopause. So the other thing is that the duration of the infertility, and then your preference. How do you want us to handle your infertility? Then it is very, very important for us to know that the management of infertility is quite demanding. So you need financial commitment, your time, and your physical commitment. Because most of the time, the investigations are very expensive, they are time consuming, and your physical own presence to be there such that you can be attended to. So it needs for commitment. You need to be serious, you need to pursue it, and our prayer usually is that you succeed. Otherwise, most of the time, the problem may not be solved. But however, it is very, very good for us to do what? To try and make sure that we follow up for treatment. Treatment options, what do we have? We have what is called the intrauterine insemination. If after we have investigated and we find that there is really no problem with you, what do? We get your sperms and your egg, we put them inside the uterus. Okay? It can be done like that. And then peradventure, fertility or the egg can be fertilized and then a baby comes. The other thing is what we call the in vitro fertilization, where we collect the ovum and the sperm in the laboratory, and then we analyze it, make sure that they are of good quality, both the ovum and the sperm, fertilize it inside the test tube in the lab. Then that zygote or that fertilized egg is transported and be put inside your uterus, and it can implant. So that is what is called IVF, and it is done so in conditions whereby you have tubal blockade. There is no way your egg is going to come from wherever it is, from the ovary to the tube down to the uterus. So we have to aid it by harvesting those eggs quite from the ovary and get the sperms.
Thank you so much, Dr. Kiden. Dr. Kiden, can you hear me?
Yeah.
Thank you so much. I'm very impressed by how you've given us that outline, and the way that you have actually emphasized that infertility is not only the woman's issue, but it is also the male's issue, and therefore both need to be investigated. And the fact that you have also emphasized that this is something that needs time, that needs financial commitment, is a very important point. And I'm so grateful for all the insight that you have given us. That was a very good overview of what infertility is and how it's investigated and how to treat it. Thank you so much, Dr. Kiden. Next, we will go to Miss Viola. Miss Viola, if you can unmute yourself, please. Miss Viola, can you hear me? Miss Viola?
Yes. Yes, I can hear you.
Okay, great.
I can hear you, Dr. Ann.
Miss Viola, thank you. So I know UNFPA deals a lot with policies against gender-based violence, and this is something that you have been able to be involved in, and you have a passion to actually advocate against gender-based violence. So could you please just give us a brief overview of how gender-based violence affects reproductive health, and what policies or strategies are in place to reduce it, and especially what role has UNFPA played in reducing GBV and caring for survivors? Thank you.
Okay, thank you very much, Dr. Ann. I will start with the policies. To start with, South Sudan lack comprehensive policies on issues of reproductive health and rights. However, these issues are included in a number of strategies and like national health strategy, like Women Health Initiative, and other rights, including the Bill of Rights under the Constitution that recognize the right to be in a union, the right to have children, and the like. The world itself recognized reproductive health as human rights in 1994 in Cairo, when they did the International Conference on Population and Development. At that particular time, South Sudan was not born yet, but it was part of Sudan. So for over the years, South Sudan UNFPA has engaged with the Ministry of Health to ensure that reproductive health and rights are enshrined and achieved by every South Sudanese, not only women, but men, boys, and the elderly. So coming to what the government, in terms of policies, the government right now has a draft policy on reproductive health and rights, which they have promised and committed to have it passed, especially if the parliament convenes. We also have a draft anti-GBV bill that is in place already. It was drafted by the Ministry of Gender in support with the Ministry of Justice. So those two policies and the bill, the government has committed that this needs to be passed, and South Sudan needs them as we speak. So we put our fingers crossed and hope that as soon as the parliament convenes, that these policies will be able to be realized. Now, UNFPA is the UN agency on issues of reproductive and rights, and they have been working on a number of issues, but we specifically have 3 issues that I want to mention. We aim at having zero unmet need for family planning, and then we need to have zero preventable maternal death. Not all death, but those preventable ones need to be put to zero. And then the third one is zero gender-based violence, including harmful traditional practices. This is the strategy that UNFPA is implementing, and that aims to achieve those 3 zeros, including where we work and South Sudan included. So UNFPA supports programs that are tailored to different challenging, and then we look at issues, what are the reproductive health issues of adolescents, girls, for example, and boys, the young people. So these programs are tailored based on the needs, the South Sudan needs.
Are you coming to down?
Now, in terms of what government has done with UNFPA, government is leading the implementation of what we call the Strengthening Midwifery Program. As you know, one of the issues we talked about earlier on is the lack of the skilled birth attendants, lack of professional gynecologists or midwives to be able to deliver children safely. 85%, I said earlier on, still are delivering at home, and that could be the reason why we have the highest maternity mortality rate in South Sudan. So UNFPA has worked with the Ministry of Health. They have trained midwives, professional midwives that go through course for 3 years. And now from 8 midwives before the independence, we now have over 800 professional midwives that are working in different health facilities, some employed by NGOs, some employed by the government facilities. Now, to come back to gender-based violence, yes, gender-based violence affects reproductive rights of women and men. Now, the link is that, for example, when you take like rape, for example, which is one of the type of gender-based violence, when a woman is having a forced intercourse, that can affect the passage. The woman can have tear, the woman can have painful intercourse, and that itself means she did not consent for it, and it violates her right to have sex when, with whom, and how many times she pleasures. So reproductive health, gender-based violence, reproductive health in that way, it can cause other issues like unwanted pregnancy, which is a very main element of reproductive health. It can cause transmission to HIV and AIDS and other STIs that are related to rape and other gender-based violence. So there's an interlink, and that's why gender-based violence and issues of reproductive health for UNFPA are seen as 2 sides of the same coin. Now, just to briefly, and this will be my last point, I want to just mention a few things that when we talk about sexual reproductive health and rights and the effects on women and girls' lives, is significant, transformative, are lasting. So issues of reproductive health and rights benefits the whole country, and they have positive impact both in terms of gender equality. We know that when women are not able to exercise or space the number of children they want, they will not be able to secure probably competitive jobs and other things. So they become very, very, very important. And then through access to family planning, and here I want to say that when women cannot time and cannot take control of their bodies, they will not have time to spend on having an income and doing other important elements that can, and allowing them to participate in the political atmosphere of what they want to do and achieve their things, important thing they want to achieve. Now, sexual reproductive health and rights can only be realized when the society change its perception and treat the rights of women and girls equally, and equal relationship are promoted and are healthy. So until we realize that women can also desire to have pleasurable sex in a marriage, that it's not a man all the time to ask for it. A woman can ask for it, and it is her right to get it. And not just when she's going to be pregnant, that she can also have sex because she wants to experience the pleasure. Then we cannot say we have achieved sexual reproductive health and rights. So in South Sudan, we still have a lot of things. Women still don't exercise fully their sexual reproductive and health and rights, the society, the cultural aspect that Dr. Ayak talked about. So with that, I think I'll stop from here, Dr. Ann.
Thank you so much, Ms. Viola, for giving us that brief overview and also telling us a bit of what UNFPA is doing in conjunction with the government to ensure that reproductive health in terms of access even is looked into, and that children, that women are actually protected against gender-based violence. And I think I like the explanation that you've given about how it affects reproductive health in actually all spheres of life, and especially with the fact that it also takes away the ability of this woman to actually take care of herself financially and economically, and that ends up in a very vicious cycle that ensures lack of access, further lack of access. So we'll go to Nyagwa. In the interest of time, we might have to skip some of the questions that we have. So Ms. Nyagwa, if you can just unmute yourself. Ms. Nyagwa, if you could just unmute yourself, please. Ms. Nyagwa.
Can you hear me
Thank
now?
you so much. Ms. Nyagwa, I know that
Yes.
you have dealt a lot with refugee health and refugee women, and there's a lot of forcing into child marriage and sexual exploitation. What are some of the factors that you think contribute to this? And what are the laws that actually protect women, especially from vulnerable population, from some of this exploitation and from denial of their reproductive health rights? Miss Nyagwa, you can go
Thank
ahead.
you for the question. In Uganda, you have to be 18 to be married, and same as in Kenya and also in Ethiopia. But what I've learned, can you hear me? Can you hear me now? Can you hear my, can you hear me? My network is so bad. Oh, okay. Sorry about that. The network is in and out in my house today for some reason. Can you hear me now? When it comes to
Ms.
the
Nyagwa,
rights of the
I
young
can
girls
hear you.
in
I'm
refugee camps,
using,
mostly in Uganda and
another
Kenya,
medium to hear
the
you.
age
Go
to be
ahead.
married is 18 years old. Okay. I don't know where I left it off. Like, for example, in Uganda, you have to be 18 years old to be married, and same as in Kenya. But there's a loophole with the South Sudanese. What they'll do, they will take the young girl to South Sudan to be married. I've seen even as young as 12 years old in Ethiopia being married off to a 45 years old guy. So when it comes to the young girl's reproductive health right, when and how does she have that right when she's 12 years old, and how can she speak up for herself? So in the refugees camp, I've seen there's a lot of violations of women's rights in the camps, and there's a need to they need to be addressed, to be honest, and especially in Kakuma and especially in Ethiopia, when it comes to the South Sudanese community. By law, like as a refugees, displaced child has a right of protection of her right, and the government has access to, he or she has to have access to those services. But when you are refugees, you don't have access to those services. How do I say this? My biggest problem working with the refugees, especially in Kakuma, is the young men from abroad. They will come, marry a young girl under age 12 years old, get her pregnant, move back to US, and every year the guy will do the same thing, comes back, get her pregnant, go back. What right did the young girl have when it comes to that? She does not. And the young woman stays with the family of the young man. So she goes through a lot of gender-based violence, abuse, and she has no access to education, and she's just stuck there. So when there's a big need for sex education, as Dr. Yak mentioned earlier. We need to have those conversations, not only with our kids, but also when it comes to cultural norm, sex education in our household it's not there. There's a need that we need to start having this conversation, because now with the new generation, young girls are exposed to social media and they're going to ask a lot of questions. And as a young woman, she needs to feel comfortable to go come and talk to her mother about sex. But I think my mom is sitting next to me, and we've been very comfortable talking about sex since I was a young girl. But when I go to other South Sudanese household, you don't have those conversations. And with our new generation, with Dr. Kide, Dr. Ayak, Viola, I hope we can change the next generation and have this conversation with our kids. As Dr. Ayak says, she's talking to her 4-year-old son. I have 2 daughters, which I need to start having this conversation with. But as a South Sudanese community, we need to start talking yesterday about sex education, and whether we like it or not, because as we speak, our kids are changing, our culture is changing. We can't stick to our old ways. And as a catwalk to freedom, we try to push those little boundaries, this uncomfortable conversation that people don't want to have. And when I have this conversation with these young girls and their parents, you can see the father, the mother just cringing, hoping that this conversation ends soon. But if you look at the young girl, she's actually intrigued and she wants to know, because her friends do talk about this stuff. But there's no safe space for her to talk about sex in the household, because, in South Sudan, we don't have space for that. And I hope in the next generation we can change that. We need to start having sex education classes. That's all I can just say, to be honest. Yeah. And the conversation like this needs to continue, and we need to talk more and more. I've learned so much today, and we hope we can expand this. Thank you.
South Sudan is still very far. Very far from all.
Thank you.
Thank you, Nyagwa. I think that's quite informative, and I think we're going to go a little deeper into that discussion about having the talk with our children, and especially our adolescents, because they're going to become sexually active quite soon. And I think Dr. Ayak mentioned a few things about that. But before we go to Dr. Ayak, I think we'll go to Ganiri. Ganiri, if you could still unmute yourself. Thereafter, we will discuss with Dr. Ayak the issue about sex education for our children. So Ganiri, if you could just give us some of the myths and some of the cultural practices that we've come across, and how, especially when it comes to the nutrition of our mothers, when it comes to nutrition that affects reproductive health, what are some of these cultural practices and some of these myths that negatively affect the nutrition of women, and what can we do about them?
Thank you so much. I will start off by something about our cooking practices as South Sudanese. At some point, we tend to overcook what we eat in the form of vegetables. For example, we know very well most of vegetables have vitamins, but these vitamins are heat sensitive, soluble. Yeah, so when we overcook our vegetables, maybe, so we end up missing out on the heat-sensitive vitamins and vitamin C, and also overwashing of these vegetables also make us lose some of our vitamin B and C. It's always advisable that we actually wash our vegetables before we cut them or we chop them. So it's always more advisable. Our cultural practices, some hinder women from getting the best nutrients. For example, in my culture, women at some point are not allowed to eat meat. I mean chicken or eggs. And I've been told, I think among the Dinka community, they're not allowed to eat mutton because they believe the as a sheep. I don't know if it still goes on or if it was just something like a myth. So these cultural practices somehow also hinder women from getting the best nutrients. So there's other cultural practices. The girl child, they tend to like if we are cooking, we give the cream of the food to our men. Look at a pregnant woman who maybe higher protein content, and she's serving the biggest part of chicken to the man and end up eating the soup. So do you think this cultural practice is actually okay? No. So so good. So we also have these misconceptions about food preferences. So people have their own foods that they prefer to eat, regardless vis-a-vis their nutritional demands. So they eat what they feel like they want to eat, which is not really good for at some point of their reproductive health. We, like Ariane had said, at some point there's demands of certain vitamins and proteins compared to what we eat. For example, you can be pregnant and you're craving maybe fried potatoes, but that's not healthy for you. But that's what you prefer to eat. So this question of having food preferences, and also there is we have like, for example, our cultures back home, there's a point when we don't have certain foods at this particular period. For example, in the dry season in South Sudan, you may not be able to get vegetables or fresh or some other thing. So some other parts don't have fresh milk. If we say like the Western, they may be laying some fresh milk compared to this Northern Baragazel and the cattle rearing communities, our Nilos brothers. They may have, so this kind of cultures of this one being farmers, this one being cattle keepers, it also differs. It also affects our nutritional status. We also have other practices, people who are alcoholic, taking a lot of coffee. You know, most times we see our women boon all the time, some coffee, this black coffee, and some may be pregnant, they still continue with their normal practices of taking coffee, even taking a lot of tea. We know very well the tea has some tartaric acid that at some point may not be so healthy for reproductive health. We also have the soft drinks, those who are able to afford. There's the carbonated drinks, the sodas, the energy drinks. It's also not a good practice that can that hinders our nutritional status of a person. We also know very well some other practices not only affect their conception part, we also have the postnatal levels. We know very well at some point people may not really want to breastfeed, and yet we know very well breastfeeding is very vital for the baby. It's also good for us, the woman. The doctors can prove it also affects, it also prevents us from having the breast cancer and the ovarian cancer. It also enables the woman, the stomach to contract back. I mean, the uterus in particular, as she's breastfeeding, the uterus will be able to contract back. And this also increases the energy levels, caloric levels, and as I said, a postnatal woman may be able to increase her calorific levels. So some of our practices of baby failure to breastfeed may be able to deny us the chance to get back to shape. We know very well when you're breastfeeding, calorie levels are high, and you're able to lose some maternal weight, like I talked about the obesity earlier on. So these are the few practices that you may think that can affect nutritional status and affect reproductive health as well.
Thank you so much, Ganiri, for some of those insights into our culture. We are not denying our culture. We're not saying that our culture is wholly bad, but some of the practices that we have should actually be gotten rid of because it affects our women's reproductive health, especially most of the ones that say that women should not eat this part of a chicken or this kind of food. And yet it's important for women to have a balanced diet in order that their reproductive health might be where it's supposed to be. So in the interest of time, we will go to Dr. Ayak. If you could unmute yourself, and Ganiri, if you could just mute yourself. Dr. Ayak, if you could unmute yourself. So if you could just talk to us a little about what Nyagwa was talking about, the issue of sex education, especially when it comes to adolescents who may become sexually active and have been discriminated against in terms of reproductive health services, and what can be done about that. And after you finish that, maybe you can also talk about abortion and some of the terms that are used in abortion, because we know that if adolescents are not empowered with information, then they might end up with early pregnancies, and this might result in issues with illegal abortion. So if you could just transition from adolescent health and how we can make sure that they have the information they need for their reproductive health, and go into a little discussion about abortion, what it is, what some of the terms used around it are, what some of the medical indications are, and what are the ethical issues that surround abortion. And if possible, we could keep the discussion to like 5-6 minutes max, because we're almost winding up. Thank you.
All right. Very well. Thank you very much. So sex education is defined as the instruction of all issues relating to human sexuality, which now there is a huge range of, definition of sexuality. And that includes emotional relations, responsibilities as well, human sexual anatomy, not the banana and the mango, the penis and the vagina, like that. And sexual activity, what does it mean to be sexually active? From in layman, from fondling and touching, all the way to penetration, all the way to oral sex, all the way to the fetishes, everything, that the huge spectrum of what it means, to be sexual active, because what constitutes a sexual activity for one person might not necessarily constitute sexual activity for the next. That also includes sexual reproduction, and issues of age of consent. That is all part of sex education. What is the age of consent? And mostly it's 18 and above. It's an age where you're considered, a viable human being, an adult that is able to make rational decisions. But not just that, that also includes things like, drugs that might, date rape drugs. That conversation also goes into, implied consent, no meaning no, and not twisting your words, because there is this assumption now in our culture that if a woman says no, she actually means yes. So here there is that emphasis. It also takes us through it also takes us through what safe sex means, and that also covers, you know, contraception, and that aspect that we have already talked about. It also talks about abstinence. So this assumption that when we talk about sex education, we're encouraging our young ones to just go out there and just have sex any which way is absolutely wrong. It is empowering our children to know, you know, because knowledge is power, so that they could discern whether they're being exploited or not, so that they could protect themselves, so that they could, have the upper hand in negotiating what they're willing to do in a sexual setup, etc., etc. So it is a comprehensive sexual education, which again also talks on the emotional aspect, and there is a lot of emphasis on responsibility. And this is usually, you know, by caregivers, formal school programs, public health campaigns. I want to highlight the UNFPA because it was, you know, it has been where I started my reproductive health work as a peer educator. There is a lot of peer education, and there is sex education incorporated into peer education programs. There are also youth-friendly services, which we still do not have, but we're strongly advocating for. Now, in the interest of time, just to slide into abortion, because once again, if you're not empowered enough, you might find yourself in a situation where you're seeking abortion. And abortion is the termination of a pregnancy. And that means it could either be spontaneous, and it's usually the preferred term for that is usually a miscarriage, or it could be induced. And it could be induced, medically, therapeutically, under a medical setup, or illegally, self or in a medical setup as well. Just before delving into that, we want to talk about some trending terminologies regarding the abortion debate. You hear a lot, a very big debate on the pro-life and the pro-choice movement. This has even informed politics at the highest level, Peace Security Council, nations like the United States, the Democrats versus the Republicans. So it is a very, very big deal. Even within medical practitioners, there is a big debate on pro-life and pro-choice. And pro-life simply means it is a belief that all life is sacred, and that the woman no one has any right to terminate a pregnancy, irrespective. If you're pregnant, then you have to see it through, irrespective of what the outcome might be, because there is the sanctity of the life of the fetus. And that is really emphasized in this movement. And then there is the pro-choice movement, and this is more on the allowing women the right to choose whether they should have an abortion, and that choice is an informed choice. So it gives women autonomy over their body, and it also respects their mental faculties, that they do have the capacity to make informed choices as to whether they want to have a child or not. So these are the two trendy issues. Now there's also another issue. What is a safe abortion? And safe abortions, they're usually conducted under medical supervision or under health supervision in a health setup. These are there is even a whole WHO guideline that was issued in 2019 on how to conduct safe abortions, categorizing them from abortions that can be done via pills before the 13th week, which is the first trimester, 3 weeks, 3 months of the early pregnancy, to 14 to 28 weeks, which is later on in the pregnancy, and it is a whole classification which I will not go into. But what I want to add is that safe abortion also includes the introduction of a contraceptive method, usually injections or intrauterine device, right after the procedure to protect whoever is having the abortion from having an unplanned pregnancy in the future. And then we have indications for abortions, and these indications are usually based on it's a balance between the wellness of the fetus and the wellness of the mother. And mostly if the fetus is determined to have either from genetic or environmental factors to have an anomaly, a genetic anomaly, like now we have the issues in Upper Nile and with the oil pollution and how that is affecting, the fetuses that are formed. These are some of the issues that warrant for a medical abortion. Because now there is a amniocentesis, there is a way in which you can determine whether the fetus is genetically healthy, and it allows for that choice. Or if the fetus is implanted in the wrong place, ectopic pregnancies, and it's affecting the mother, like Dr. Kiden earlier mentioned, or if the fetus, intrauterine demise, they call it in the medical field, if the child dies, in the womb, then it has to be, evacuated. Other reasons, maternally, is based on the maternal health. If the mother cannot carry this child to term, and if it is detrimental to the child's health, irrespective of what it might be, she has the right to an abortion. And then we have medical legal issues. We have issues like rape. We have issues like incest, where you have a right to request for an abortion. So there is that. The debate is still ongoing. I know as South Sudan, earlier Viola spoke about the policies. We have ratified the Maputo Protocol, which is part of the African Charter on Human and People's Rights, with reservations on Article 14, which has a subsection that speaks about the pro-choice. So there is still that debate, but generally speaking, those are the key terminologies that are used in regards to abortion.
Thank you very much, Dr. Ayak. That was very insightful, especially going into some of the words that we use when it comes to talking about abortion, and also talking about sexual and reproductive health, and how we can introduce the topic to our young ones so that they're informed and empowered to make decisions about their sexual and reproductive health. Finally, Dr. Alec has been able to join us. Dr. Alec, could you please unmute yourself, and then we'll just have like maybe 3 minutes to answer a question. You were specifically going to talk to us about some of the challenges that affect women living with HIV, especially when it comes to accessing reproductive health services. You could give us like 2 minutes information on that. Thank you for joining us finally. Thank you. So challenges that affect women living with HIV.
Thank you.
Reproductive health that affect women living with HIV. Thank you. 2 minutes, and then
okay. Thank you, Dr. Ann, and I'm sorry for the technical. Thank you so much. Yeah, when it comes to women with HIV and AIDS, they have the same rights as the other women, of course. And the challenges are more because now the situation is more doubled for them. So the challenges that I will emphasize on is the lack of integrated services, the one that they can access to, especially when it comes to reproductive health, and also contraceptive, and also family planning, right? So all of these services are not integrated together so that the women living with HIV/AIDS can access those services. And also we know in Africa, and especially in South Sudan, we have weak health systems. So these weak health systems are affecting women accessing in general. So when it comes to women with HIV/AIDS, it is more than the other women, of course. So this is one of the challenges. The other challenge as well is the stigma and discrimination against women living with HIV/AIDS. The women living with HIV/AIDS normally they face discrimination and stigma when it comes to accessing the health services. And the one that affected them more is the stigma from the health workers. We know that health workers, when they are not trained very well, they have a tendency to stigmatize women living with HIV and AIDS. So this stigma affects the women accessing those health services. Maybe health services, when they are available, women cannot access because of this stigma of healthcare workers. The other challenge that I can talk to is also regarding the information. I'm not going to talk about it because it was actually addressed earlier regarding the sex education and sexuality in the schools system, or to be accessible to all the women, including women living with HIV and AIDS. So this is also one of the challenges that are affecting women living with HIV and AIDS. So when it comes to the recommendation that we're supposed to regard is is actually addressing those challenges. So to have the recommendation is to address the challenges that we have and try to correct the inequalities in the system that we have. So one of the challenges that I said earlier is the stigma and discrimination. So we can correct that, but having training of health workers of how to deal with women living with HIV and AIDS. So one of the challenges that I also mentioned is strengthening of health systems as well. So to have a health system that is integrated together, so that a woman living with HIV and AIDS can access all the services at one-stop shop, to have a family planning together, to have access to HIV and AIDS treatment, to have all the reproductive health issues combined together. So this is what I think that could help the women living with HIV and AIDS, and also in the communities, because we know that also we have this issue of discrimination against women living with HIV and AIDS in the communities. So correcting that together, it means a lot to women living with HIV and AIDS. And also we have one I can also recognize is the self-stigma itself, because women cannot access the health services if they have a self-stigma, if they cannot acknowledge that when they are sick, they need to go to healthcare or to access healthcare, and also if they are HIV positive, that also they have the right to go to any healthcare facility wherever they have. So, and also one of the crucial issues that we were supposed to pay attention to is if we have this stigma in the health or in the communities, and also in the if they are HIV positive. I'm sorry, there is an echo.
Thank you so much,
to correct,
Dr. Alec, for that information that you've given us. And very grateful that you were able to join us finally. Sorry, I have a bit of an issue with some of the networks, but I'm glad that you have been able to join the conversation and give us a little overview about the challenges that that women living with HIV have when it comes to reproductive health. And especially, I think it's important what you've talked about, a one-stop shop and integration of reproductive healthcare services, especially for women who are vulnerable to stigma, the HIV infected women, adolescents that we talked about, and even refugee women. Now, because of time, we'd like to wind up, so I'll give Dr. Kiden an opportunity to just give us a 3-minute overview of what some of the best practices are when it comes to taking care of pregnant mothers, pre-conception, during pregnancy, and post-conception. Dr. Kiden, you can just give us a few points and give us these few points under 3 minutes so that we can go to the conclusions. Thank you. Dr. Kiden, if you could unmute yourself. So 3 minutes, Dr. Kiden. Sorry, it's
Thank
too
you
much
very much,
information to
Dr.
cram in 3
Ann.
minutes. Thank you.
All right. The best practices when it comes to pregnancy, from the time you conceive to the time you deliver, and finally you are declared to be you have gone out of that period, the postpartum period. What are you supposed to do before you conceive? Ladies, let's learn how to seek screening for diseases that can affect the outcome of the pregnancies that we are carrying. It is important that you conceive when you're healthy. Diseases like diabetes, diseases like hypertension, many others. If you conceive by the time you're conceiving and they are not under control, the likelihood that the outcome of that pregnancy will be poor is very high. So before you conceive, please make sure that you go to the hospital, do some screening for HIV. You can do screening for CA cervix. You can do screening for infections like chlamydia, rubella, and all those that can cause congenital malformations in the baby. Secondly, after you have conceived, please go to the hospital. Make sure that you attend your ANC. Do not wait until when there is a problem that has developed. That is when you can go to the hospital. Attend your ANC promptly in the first trimester. Please do go. Let them do the screening in the second trimester. There are diseases that can develop during the pregnancy in the second trimester, and there are those that can also develop, complications can develop in the third trimester. So please do not wait for people to first coerce you to go for ANC. It is your responsibility. It is your right. It is within your reach. I am very sure that there are so many ANC facilities that can offer you the services that you need. Secondly, the tendency for us to deliver at home is unacceptable in this century. South Sudanese women, we have to be very, very, very wise. We have been always wise. We have been always very wise, and I know that we can do it. Please go and deliver in a hospital. We have lost many mothers. It is very unfortunate because we tend to deliver from home, simply because I think there could be some pressures from the family or traditional practices, or you even don't trust the health workers. And that has costed us a lot. Therefore, I would recommend that when you are going to deliver, please make sure that you go to the hospital. Don't do it at home, because you can bleed and finish your life there. Secondly, after you have delivered from the hospital, when you go back home, be careful in assessing services for complications that can develop thereafter. Things like sepsis is one of the major causes of maternal mortality and morbidity in Africa and in our country particularly. Please come when you see that things are not moving on normally. Don't begin to say that this is what, I think probably this is what women go through after they have delivered. You're oozing pus, you're having high temperatures, you are having the breasts are engorged. You don't know what to do. Please make sure that if you're not feeling well, go to the hospital. All right. So with that, I would say that please make sure that you're the custodian of your own health. Make sure that nobody should deny you the fact that you need care when you need it. Okay, I think that would be enough for now. Okay.
Thank you so much, Dr. Kidem. You've kept time and you've even given a conclusion and your recommendations, and I'm very grateful for that. So I think we'll just go around with the panelists, giving their conclusions and their recommendations, 1 minute each. And I'm very grateful for your participation today. So we can start with Ganiri. You can give us your conclusion. And then Dr. Ayak after Ganiri, then Nyagwa, then Viola, and then we can end with Dr. Alex. So Ganiri, Ayak, then Nyagwa, then Viola, and then Dr. Alex can finish for us. Thank you.
Thank you so much. In concluding, we know very well what we eat is what our body is and what our children will be in the future. So the major points here is you eat a balanced diet. Earlier I talked about my plate and what a balanced diet is. It's also good to diversify your food, what we eat. We eat, like we say, when in Rome, do as the Romans do. Don't be in Uganda or in Somalia or wherever and think of what you should be eating as what is in South Sudan. Eat what is available. It's what these people have been living on, and so nutritional. Okay, diversify your foods. Eat whatever is available. So we also on government level or as policymakers, we also tend to make to do fortification. The government does fortification of some manufactured products. We know the oil, our table salt, and all that. We also have to do exercise. We do exercise. I don't know if somebody has known about the Kegel exercise after delivery to keep the body fit. We have to do the exercise. Somebody can go and read about KEGEL, Kegel exercise. We need to do exercise. Then we have to know that supplements is not a medicine, like how you can talk about paracetamol or quinine or amoxicillin. It's just addition of what we might have missed as we're eating. So we should also make sure we take our supplements well as we're given by the doctors or midwives. And we also know that we have to prepare for motherhood from adolescence. And also, even though at 35 years and above, some women are supplemented with calcium. So we take it as just our normal meals. It's not really a drug. It's just some like food to top on. We should also breastfeed our children. It has a lot of advantage compared to formula milk. Where possible, we can even express. It's all about combined effort of nutrition for good health and prevent other issues like congenital defects, neurotube defects in our children, and safe motherhood and good weight. Thank you.
Thank you, Ganiri. Dr. Aya?
I want to just close by saying rape is real in South Sudan. Over 90% of rapes are conducted by close family members. Over 98% of rape is by men. So we have to validate our daughters, our sons, when they come complaining to us. Let us not hide behind these statements of rape is not our culture. It is happening. How real does it have to get? It is a very serious issue, and we need to find other ways from policy level to family level on how to address this issue with no stigma and with no shame at all. Thank you.
Thank you, Dr. Ayak. We're going to purpose to talk about that in one of our other topics. Thank you for reminding us that that is something we should look into. Nyagwa, if you could give us your 1 minute conclusion. Thank you.
Okay. Thank you for the discussion. It was very, very nice and informative. You know, South Sudan has committed to eliminate child marriage by 2030. And I hope we can sustain that goal. But however, there's currently lack of government leadership to implement those action plans. So by 2030, we hope to eliminate child marriage. As for Reproductive freedom, we'll continue educating and sharing awareness within the refugees, in South Sudanese refugees in Kakuma, Uganda, whatever they might be. If you're out there, please educate yourself. There's been a lot of information today on this forum. Repeat it again, read it, educate yourself, and stay safe.
Thank you so much, Nyakula. We'll take that into advisement to take this information and use it appropriately, and also to stay safe. Viola, could you please give us your 1 minute? Thank you.
Okay, thank you again. I just want to say that sexual reproductive health and rights can play a significant positive impact on gender equality across all aspects in South Sudan. It gives a good impact to communities and social prosperity. And this includes the women's ability to access educational and employment opportunities, leading to increased individual assets, as well as contribution to household and communities. Now, I just want to caution against the people saying the myth that family planning is bad. Now, when women access family planning, they have a high chance of maintaining jobs, and they have the high chance of contributing to economic growth of the country. So family planning is a good thing for both gender equality and for achieving women empowerment as a country. Now, one other thing I also need to say as concluding is that we need to teach our children about respectful relationships so that in the future there will be against violence, and issues of gender-based violence will be reduced. Now, I think that's it from me. Thank you very much. I'm happy to have been on this discussion.
Thank you, Ms. Viola. Thank you for that. I think what you have also implied is that we should teach our children so that they become also advocates against gender-based violence, because it actually cascades into the next generations. And I think we should also include our male children in that conversation. Dr. Alec, if you could give us 1 minute, your 1 minute. Dr. Alec, you are on mute. If you could unmute yourself. Thank you. Unmute yourself, Dr. Alec.
Yeah, thank you so much, Dr. Anne. Yeah, thank you so much, Dr. Anne, and the panelists for this good discussion. And I'm happy to be with you in this forum. The last recommendation for me is to just let everybody know that women living with HIV and AIDS have the same rights as other women, and they should not be discriminated against or have any stigma against them, because the HIV is like any other disease. It's just because it's for a life time, like diabetes or like hypertension. So it is a form of a disease as well. And I would like also to affirm or stress on the health system strengthening, because by strengthening the health system, this is how women living with HIV/AIDS can also access treatment, because they will have their slot in that place. So if we have the systems that are in place, that we will make sure that women living with HIV and AIDS has access to everything. And also another last remark is for the women living with HIV and AIDS, that also they have the right to adopt if they cannot have children of their own because of fearing to have infected children for a reason or another. Then also they have a right to adopt children and to have a family and to form a family. So this is now from me, and thank you so much for having me in this forum.
Okay, thank you very much, Dr. Alec, for that brief conclusion. Finally, we will end with Dr. Kiden, who's given us a lot of information about the clinical aspects of reproductive health, and we're so grateful that she has been able to show us the medical side of this conversation. So, Dr. Kiden, I think you can give us an overview of what your conclusion is and a few recommendations as we close. Thank you.
Thank you very much, my fellow panelists, for this fruitful discussion that we've just had. I just want to make a conclusion by saying, as I had already alluded earlier on, that we women, we have got the power within our reach to control our own health. Secondly, make sure one of the major messages from the ICDP on 25 in Nairobi that was held last year, one of the major important messages that they are sending out is that reproductive health rights they are to be looked into by those that want to achieve the universal health coverage by making sure that reproductive health and rights are observed from the time the child is born to childhood, or that is infancy, childhood, adolescence, then your reproductive age into adulthood, and finally into menopause. So the woman should be looked after and her rights as far as sexuality is concerned from childhood. So I could think that these things can be very, very much theoretical if we don't have goodwill and the political will towards achieving these rights for our women. I would think that we as mothers, we have a very major role to play to make sure that our future in our girls is secured. Make sure that you teach that girl all that it needs, that she needs to go to school. Send that girl to school. I'm telling you, we can talk about many things, but if we don't invest this knowledge into the young generation, then we will have failed. So teach that girl in the house and send her to school. Tell her that she will be independent and be able to make decisions for the entire of her future. And teach that young boy in the house, your very own son, before you go out, teach him to respect the sister. When he goes out, he will respect other women outside. Okay, so in that way, we'll have started on a very good fight. Otherwise, we can wait for the politicians to do what we want them to do, and they are not forthcoming. Okay, so that is my conclusion. Please, I am very blessed to be part of this discussion, and I look forward to meeting you again. Thank you.
Thank you so much, Dr. Kiden, for that conclusion. I think you have basically summarized everything. And the main points that I've gotten from this discussion is that knowledge is power, and that we need to empower our women and also our girl child. And we should also involve the male children and our men in the conversation, because if they are not involved in the conversation, then access will continue being an issue. And the fact that this is an equality issue and the effects of denial of reproductive health services and rights is actually a human rights issue. And the consequences can be fatal in the sense that they can cascade down to future generations, because these women are going to be responsible for bringing in the next generation into the world. And if their health was not taken care of, and if their rights are not taken care of, then the children that they bring into this world will also suffer. I want to thank all our panelists, Ms. Ganiri, Dr. Kidane, Dr. Ayak, Nyagwa, Ms. Nyagwa, and Dr. Alek, and Ms. Viola, for taking part in this very important conversation and for agreeing to spend your time to educate our women on reproductive health and rights. And I'd like also to thank our audience for participating, for listening, for sharing this video. And we hope that we have been able to empower you with some knowledge. And from now, you can go on and become advocates for reproductive health and rights, both for yourselves and for the women in your lives. Thank you so much for taking part in the show, our panelists. We are so grateful. And on behalf of the South Sudanese Women's Intellectuals Forum, we want to thank you so much for taking your time to be part of this. Thank you, and goodbye to everyone. Thank you.